Hello, everyone. My name is Lashunda Thomas, and I am here to present to you my DMP project titled Identifying and Improving Adolescent Depression at the Primary Care Level. This is in partial fulfillment of the DMP program at Maryville University. I would like to thank the committee members here at Maryville University. I would also like to thank the Maryville University faculty and staff who assisted me throughout this process. And I would like to give a special thanks to Dr. Rita Wunderlich, my DMP chair. So adolescent depression is a growing health concern that can occur on any block in any neighborhood worldwide. Although challenging within itself, even more challenging is undiagnosed, underdiagnosed, and untreated adolescent depression, which could lead to debilitating outcomes, even death. Guidelines recommend routine screening for depression for adolescents aged 12 to 18 during their primary care visit. Primary care clinicians can screen and identify adolescent depression, although their engagement is low. To mitigate change, it is essential to address this growing concern, which will improve depressive outcomes and globally unify practice change. The purpose of this project was to identify if the PHQ-9 modified for teens, an evidence-based depression screening tool, was being adequately used at the chosen clinic, and to determine if the screening tool increased post compared to pre-implementation referrals for psychiatric treatment and if education was provided as necessary. The question for this project was, in adolescents aged 12 to 18, is the use of a depression screening tool used in a primary care setting compared to practice without the use of a tool helpful in identifying depression, and are clinicians initiating appropriate referrals and/or treatment at the time when depression is identified? To give a little background regarding adolescent depression, undiagnosed, late diagnosed, and untreated adolescent depression cripples the mental health care system and patient health. In the United States, in 2020, it was estimated that 2.9 million adolescents experienced at least one major depressive episode that led to severe impairment. Among depressed adolescents aged 12 to 17, 18.8% seriously considered attempting suicide, 15.7% made a suicide plan, 8.9% attempted suicide, and 2.5% made a suicide attempt that required medical care. Guidelines recommend routine adolescent depression screening in primary care, which aids in an accurate diagnosis, treatment, and follow-up care. Research shows that effective screening programs for depression utilized in primary care settings have resulted in improved mental health outcomes. Despite guidelines and research, 50% of cases of adolescent depression are missed, and fewer than 35% of cases go untreated. Hence, addressing adolescent depression is critical to improving mental well-being. When we talk about the significance of adolescent depression, following puberty, the risk of depression in the adolescent population increases by a factor of 2 to 4. 5% to 6% of adolescents encounter mild symptoms of depression, although 30 to 35% experience elevated symptoms that are missed by nurses and other healthcare professionals. Globally, major depression disorder is the leading cause of years lost to disability among the ages of 10 to 14 and 15 to 19. Between the ages of 15 and 19, suicide is the third leading cause of teenage death. In terms of the financial burden, The cost of depression in the United States is estimated at $210 billion per year. This project was supported by the clinic's staff, the Maryville Institutional Review Board, my DNP chair, and Maryville faculty. Regarding the benefits to practice, this study is relevant to practice as adolescent depression without a proper diagnosis and prompt treatment can be debilitating and life-threatening. The patterns of worsening depressive outcomes without early diagnosis and treatment, which could lead to suicide, signifies that community efforts to improve depressive outcomes are greatly needed. Primary care providers could significantly improve the mental health well-being of adolescents affected by depression by consistently screening, thus improving psychological health. A literature review for this project was performed to explore studies backing the recommendations to screen adolescents for depression in primary care. Also, the literature review was performed to identify screening tools and to identify barriers to care for clinicians. 10 articles were utilized and grouped into 4 themes. The themes included the significance of adolescent depression, late detection and inadequate treatment, screening tools and guidelines, and barriers for primary care clinicians. Given that I have discussed the significance of adolescent depression, I will not go into this again in detail, but I will reiterate that the risk of adolescent depression increases after puberty, and depression is a leading cause of disability in this age group, as well as suicidal behaviors, suicide attempts, and suicide completion. Looking at late detection and inadequate screening, when undiagnosed, late detected, or untreated, depression strongly predicts suicidality, suicide attempts, and inpatient psychiatric hospitalizations. Late detection and inadequate treatment of adolescent depression often leads to poor long-term social outcomes, suicidality, and worsening depression as an adult. Studies have shown when undiagnosed or untreated, 60% of children with depression will have a reoccurrence in adulthood, and 50% of undiagnosed, underdiagnosed, or untreated adolescent depression is strongly linked again to adolescent suicide. Other worsening outcomes of undiagnosed, late detected, or untreated depression include social impairment, substance abuse, anxiety, unsafe sexual practices, recurrent depression later in life, and poor academic performance. As far as screening tools and guidelines, routine screening is an essential part of improving diagnosis rates and reducing the overall negative outcomes of depression. I can't stress that enough. The U.S. Preventative Services Task Force recommends routine screening for depression in adolescents aged 12 to 18 in a primary care setting to ensure an accurate diagnosis, effective treatment, and appropriate follow-up. The American Academy of Pediatrics guidelines for adolescent depression in primary care advocate for universal adolescent depression screening in the primary care setting. The PHQ-9 modifier for teens provides strong evidence for the specificity and the sensitivity, making it a valid and reliable evidence-based screening tool to detect depression at the primary care level. The most common barriers for primary care providers in terms of managing and treating adolescent depression were lack of sufficient training and exposure to screening and diagnosing, poor staff education and training, general disinterest or lack of knowledge in mental health prevention, inadequate administrative support for clinic staff during meetings, and lack of effective communication between members of the medical team. Lack of certainty around interpreting depression screenings, assessing safety, counseling patients about depression, and monitoring responsiveness to treatment. Lack of confidence, the need for more resources to provide and promote mental health services, inadequate training and skills, and lack of time. Kurt Lewin's change management theory was used as the theoretical framework for this project. The theory focuses on unfreezing, moving or changing, and refreezing, which facilitates change and promotes or pushes individuals towards the desired direction that ultimately becomes a part of sustaining positive organizational change. Methods. This project was a quantitative exploratory design through a retrospective chart review of 100 EMRs or electronic medical records, 50 pre and 50 post. The review were for adolescents aged 12 to 18 seen for the well child visit. Pre and post intervention data examined the frequency and the administration of the PHQ-9 modified for teens and if appropriate interventions followed, and those interventions were noted as referrals and education. The results of this project determined if there was a statistical significant impact on the diagnosis and treatment of depression after the PHQ-9 modified for teens was implemented. The Z-test was used to determine the statistical significance. Descriptive statistics were utilized to display the data outcomes. Post-intervention educational sessions were delivered to induce knowledge regarding depression screening, reinforce guidelines, and reiterate the need for ongoing depression screening in primary care. This project was conducted at a primary care clinic located in the southeastern region of the United States. Participants were not engaged throughout the project as this was a retrospective chart review. However, the chart review was for individuals aged 12 to 18. For the inclusion criteria, the participant was 12 to 18 years old and was seen in the clinic for a well child visit. The EMR had documentation that the patient was seen at the clinic during the project's time frame. The EMR had documentation that the PHQ-9 modified for teens screening tool was administered. The EMR had documentation of whether or not the patient was diagnosed with depression. The EMR had documentation that review of results and explanation of interventions was provided as recommended by the scoring guide. For the exclusion criteria, if the EMR had documentation that the patient was less than 12 years old or older than 18, the EMR was closed and no data was retrieved. If the EMR had documentation that the patient was being seen in the clinic for a sick complaint and not a well child visit, the EMR was closed and no data was retrieved. If the EMR had documentation that the patient was not seen at the clinic during the project's time frame, the EMR was closed and no data was retrieved. There was no recruitment required for this project. The author recorded the minimal necessary data to accomplish the project's goals on the data collection sheet. All patient identifiers were removed and not collected for this project. In terms of the data collection instrument, as previously mentioned, the PHQ-9 modified for teens was used throughout the process of this project. The PHQ-9 modified for teens is again the most widely used depression screening tool given the population. Specificity, 86.5%, and the sensitivity, 94.7%, was found throughout literature. Psychometric properties of the PHQ-9 modified for teens demonstrated sufficient internal consistency, which measured between 0.739 and 0.867, greater than the recommended value of 0.70. And here is just a visual of the PHQ-9 modified for teens. Protection of human subjects. The project was submitted and approved as an IRB exemption. No specifics were noted regarding the clinic's exact location. De-identified data collected from the EMRs were placed into a password-protected data collection sheet on a password-protected computer. All confidential identifying patient information was removed. All collected data for the project will be destroyed 3 years after the completion of the project, and participant consent was not necessary, considering the project was a retrospective chart review with no patient engagement. For data analysis regarding the subjects, the age range were adolescents aged 12 to 18 being seen at the clinic for the well child check during the project's time frame. Gender was not part of the inclusion or exclusion criteria. However, gender was documented to highlight gender differences in adolescent depression, which could provide data and guide future research on adolescent depression. Subjects in the study could be classified as male, female, or other. There were a total of 52 females and 48 males. No subjects identified as other. As previously mentioned, the main themes for this project were to focus on frequency of screening, number of referrals initiated, and education. As far as the results in terms of frequency of screening, of the 50 EMRs reviewed pre-intervention, the PHQ-9 modified for teens was administered 36 times compared to post-intervention, in which it was administered 48 out of 50 times. In terms of the number of referrals, of the 50 EMRs reviewed pre-intervention, referrals were not initiated 4 times when necessary, compared to post-intervention, where only 1 referral was not initiated when needed. Regarding education, out of the 50 EMRs reviewed pre-intervention, 46 charts were NA. 1 chart revealed that education was not provided when necessary, and 3 charts revealed that education was provided when needed. Compared to post-intervention, of the 50 EMRs reviewed, 44 were NA. 2 charts revealed that education was not provided when necessary, and 4 charts revealed that education was provided when needed. And this slide just shows the descriptive results for education, both pre and post data. Statistical results showed for the frequency of screening a statistically significant increase in the ratio from pre to post intervention was noted, demonstrating a change in one direction. For referrals, there was a statistically significant more ratio from pre to post intervention. However, there was insufficient information to suggest an increase in the ratio from pre to post intervention or significant evidence to show a change in one direction. For education, statistical analysis was not captured using a statistical test. However, results show that education was mostly provided to patients and caregivers when necessary. And this slide just shows the statistical results from using the z-test in terms of the frequency of the PHQ-9. And this slide shows the results, the statistical results of the referrals. Discussion. The project found that the consistent use of the PHQ-9 modified for teens administered at the primary care level can aid in identifying and treating depression. Despite the lack of statistical significance regarding referrals, there was a slight increase indicating a clinically significant outcome that is also meaningful to clinical practice. Because the PHQ-9 modified for teens were already in use at the clinic, it is likely that the clinic will continue its use with hopes to improve depressive outcomes. Given the outcomes of this study, it is in hopes that the clinic will use the screening tool more frequently. With more frequent use, missed opportunities to screen for adolescent depression can be addressed, depression can be identified, and interventions to initially manage adolescent depression can be implemented, thus reversing the poor outcomes associated with undiagnosed and untreated depression. For implication for future practice, this quality improvement project highlighted the benefits of depression screening at the primary care level, supporting evidence throughout literatures. The project noted clinical relevance to the practice setting that demonstrated solidarity in practice change, but can be the model for universal practice change regarding depression screening in primary care. For the implication for future research, it's important to propose solutions to eliminate barriers for clinicians as studies are limited. It's also important to identify and propose solutions to obliterate screening barriers for patients and caregivers as resistance to sensitive health topics such as depression and depression screenings are often encountered. It's also important to compare all screening tools to determine which is the most feasible, easily understood, accessible, and convenient to primary care clinicians, which could result in greater compliance and more consistent use of screening tools for depression administered in a primary care setting. In conclusion, undiagnosed and untreated adolescent depression is a serious health problem that can lead to long-lasting, debilitating consequences. Primary care clinicians can screen for adolescent depression, thus addressing the missed opportunities to improve depressive outcomes. This project demonstrated that the PHQ-9 modifier for teens is an appropriate screening tool that can be the solution to identifying depression and begin initial treatment as appropriate. The continuation of this project and the recommendations for future practice and research will embark on a journey to improve depression care by promoting universal depression screening that would permanently change practice outcomes. I would like to thank you, and I would like to thank everyone who was involved in making this project a success.